Greetings. Thank you all for joining us today when we present NETEC's webinar series. Today's event is about polio, specifically titled Polio Resurgence, Guidance for Healthcare Workers. My name is Jill Morgan. I'm going to be the host today, and I'm very happy to be joined today by two very knowledgeable experts. We're going to have Jake Fray from Denver Health. Jake is a point of care supervisor, and he oversees the high-risk pathogen laboratory, which is part of Denver Health and the U.S. Regional Response Network of Hospitals. And Dr. Ashlesha Kaushik, she is the director of Pediatric Infectious Diseases and Antimicrobial Stewardship program at Unity Point Health, and is a clinical assistant professor of pediatrics at the University of Iowa's Carver College of Medicine. Dr. Kaushik is an American Academy of Pediatrics national spokesperson, a CDC childhood immunization champion for Iowa, and the recipient of the National Immunization Emerging Leader Award at the 2022 National Conference for Immunization Coalitions and Partnerships. We're thrilled to have these folks with us today. All right, so for those of you new to NETEC, the National Emerging Special Pathogens and Training and Education Center sets and advances the gold standard for special pathogen preparedness and response across healthcare delivery systems with the goal of driving best practices, closing knowledge gaps, and developing innovative resources like this one. For more information, please visit us at www.netec.org. And if you have questions about today's session or anything that you would like to propose for new education or a question about processes or procedures, you can email us at info@netec.org. NETEC has three broad areas of focus. One is consultation to improve the preparedness of U.S. healthcare systems for emerging and special pathogens. We do self-assessments and have tools for self-assessment. We collect metrics and try to move facilities forward towards preparedness. We do on-site assessments and remote guidance. We also provide in-person education, online training, and have an entire online repository of educational materials. And we have a research network, which is building a central IRB and developing policies, procedures, and data collection tools to help facilities as, let's hope we don't have another pandemic anytime soon, but as events involving special pathogens emerge. So we're going to dive right into the clinical considerations in post-polio syndrome and vaccines with Dr. Ashlesha Kaushik. Thank you so much for being with us today, Ashlesha, and I'm really excited about today's presentation.
Thank you. I'm honored to present today's talk and discuss our clinical considerations for polio, post-polio syndrome, and vaccines, and discuss CDC recommendations regarding these. So poliomyelitis is caused by poliovirus. It's an RNA virus belonging to enterovirus genus, and it has three serotypes, poliovirus 1, 2, and 3. Immunity is minimally heterotypic, so immunity to one serotype does not produce significant protection to other serotypes. It's a highly infectious pathogen with person-to-person spread occurring via fecal-oral or oral-oral routes, most commonly. The fecal-oral route is by far the most important transmission pathway, especially in settings with suboptimal hygiene and sanitation conditions. Patients are most infectious in the days immediately before and after onset of symptoms. However, the virus is excreted in stool for prolonged periods for up to 6 weeks and sometimes longer, especially in the immunocompromised populations. An important thing to note is that the virus can be shed in individuals with minor symptoms or no symptoms. So when we talk about the clinical spectrum of polio, after infection, majority of the people will only be asymptomatic. So asymptomatic infection is seen as 75% of patients. Clinical illness with complete recovery is seen in the other remaining 25%, with paralysis occurring in less than 1% of all infections. So in the minority, whoever will experience symptoms, they will usually have fever, sore throat, and usually will experience complete recovery. So it's labeled as abortive clinical illness. And paralysis occurs in very, very few people, like less than 1% of all infections. And even one paralytic case indicates an outbreak. The incubation period for non-paralytic polio or the abortive illness is 3 to 6 days. However, is 7 to 21 days for onset of paralysis in paralytic polio. The virus mainly replicates in the GI tract and in the oropharynx, and then proceeds to multiply in the local lymphoid tissue as well as invasion of bloodstream, and then infect cells of the central nervous system. The virus is carried by retrograde axonal transport to the spinal cord. The gray matter of the spinal cord is affected, specifically the anterior horn cells of the motor neurons, as seen in the figure. So when we talk about the clinical symptoms, most patients have a preceding illness 1 to 3 weeks before development of flaccid weakness. Most likely, the patients will have gastrointestinal illness with symptoms of fever, sore throat, abdominal pain, muscle aches, malaise, and weakness. And then once the paralysis sets in, it is accompanied by recurrence of fever and neck or back pain and pain in the affected limbs. The onset of weakness is rapid, occurring within hours to a few days. Loss of muscle tone with sloppiness and complete loss of reflexes is seen. And the weakness usually occurs in lower extremities. It is described as asymmetric, affecting proximal muscles more than distal. So a classic descending paralysis. These are the signs and symptoms of the spinal poliomyelitis, which is the most common manifestation. Another manifestation is bulbar poliomyelitis, where you may have cranial nerve findings and respiratory impairment. The patients might present with a weak or hoarse cry and have pooling of liquids and food in their mouths. Sensory, cognitive, and bowel bladder functions are usually spared in poliomyelitis. Any paralysis which persists at 6 months to 12 months is usually permanent. Whatever recovery occurs in the initial 4 to 8 weeks, but usually majority of the people experience permanent paralysis. About 5 to 10% cases, the case fatality rate is around 5 to 10%. So all in all, it's a debilitating disease. It's a devastating disease. When we talk about diagnosis, neuroimaging is paramount. So MRI with and without contrast of the entire spine and brain, which reveals hyperintense lesions, is usually recommended. For lab testing, we need to collect specimens from the patients. So we are supposed to collect 2 whole stool and 2 oropharyngeal swabs taken at least 24 hours apart during the first 14 days after onset of limb weakness. 2 specimens are usually recommended because the shedding of the virus is intermittent after onset of symptoms. And all specimens should be routed through the state and local health departments for initial enterovirus testing and then to CDC for confirmation of poliovirus. So how will you manage the patients acutely? So for initial acute management, the most important thing is to admit the patients and to monitor the respiratory status, as rapid progression of weakness occurs within hours to days. Unfortunately, there is no FDA-approved treatment, no antivirals, medications, or biologics for poliomyelitis. There is no treatment available. Neurology and infectious disease consultations are a must because they will tell us what kind of workup and what specimens to send and help us in routing to proper authorities. And then rehabilitation therapy is a very important cornerstone of supportive treatment. Therapies such as PTOT, speech swallowing, should be initiated as soon as possible and as soon as the patient is stable. Now, there is also an antiviral called Communicable, which is an experimental investigational drug available by FDA for use only in immunocompromised populations, and it only reduces transmission and excretion of the virus, but does not do anything to prevent paralysis or to prevent progression or weakness. So there is actually no treatment available. So for infection control, we must isolate the patient in a room, ideally with a private bathroom during admission. And all the healthcare personnel should be using standard and contact precautions at the minimum. If there is respiratory distress, then they should also consider using droplet precautions. Only healthcare personnel and lab personnel with evidence of complete polio vaccination should work with patients with polio. As I mentioned, it's highly contagious, and unvaccinated people are at 90 to 100% risk of getting it. So CDC does recommend a single lifetime booster for lab and healthcare personnel who handle specimens that might contain poliovirus or else who take care of patients who could have polio. As far as reporting goes, reporting is mandatory for polio, and reporting of cases should not delay a patient's diagnosis and or treatment and stabilization. we should make all efforts to contact state and local health departments as soon as possible. And in fact, paralytic polio has been classified as immediately notifiable, extremely urgent condition, which requires that local state health departments contact CDC within 4 hours. And non-paralytic polio has been classified as an urgent notifiable disease where local and state health departments can contact the CDC within 24 hours. Now, health departments will help us complete a patient summary form and will request MRI report, images, neurology, and ID consult notes from the hospital. And then the information will be sent to the CDC's expert neurology panel for review. All this can be done while lab testing is underway and while, it should not interfere with the stabilization and initial supportive management of the patient. At the same time, we must also ensure that household contacts are up to date on polio vaccination, and special attention should be paid to hand hygiene. So in addition to vaccination, hand hygiene is one big thing that needs to be followed. So washing hands with soap and water before eating or assisting with feeding or after toilet use, etc., should be highly encouraged and should be followed meticulously. And in fact, this is not all. Like, as I said, polio can lead to mortality rates. Polio can lead to permanent paralysis. It can be a devastating, lifelong, debilitating disease. But even polio survivors can have a condition called post-polio syndrome. So adults who had paralytic polio during childhood may actually develop non-infectious post-polio syndrome as much as 15 to 40 years later. It is characterized by a slow and irreversible exacerbation of weakness, often in those muscle groups that were actually involved during the original infection. Muscle and joint pain are the most common manifestations. As I mentioned, it's a non-contagious condition and occurs in approximately 25 to 40% of all polio survivors. The cause is unknown and is thought to be related to a degeneration of individual nerve terminals in the motor units. The common symptoms with which post-polio syndrome presents are slowly progressive muscle weakness, fatigue, loss of muscle function, pain, and also it's rarely life-threatening, but does lead to significant impairment of with an individual's capacity to function independently. So the criteria for diagnosing PPS are a prior paralytic poliomyelitis with evidence of motor neuron loss, with a period of partial function recovery, with stable neuromuscular function, usually lasting 15 years or more, followed by a slow progressive new muscle weakness or decreased endurance with symptoms that persist for at least 1 year and with exclusion of other neuromuscular disorders. And diagnostic entities include imaging as well as electrophysiological studies, mainly to exclude other causes. The prognosis is a very slowly progressing condition and really is irreversible. The severity depends on the degree of residual weakness and disability and individual, whatever the patient experienced in the original polio attack. If the patient had a very bad weakness to begin with, then, they will experience greater degree of residual weakness. The people who were left with severe residual weakness may develop more severe case of PPS with greater loss of muscle function compared to those who had only a minor illness in the initial episode. Unfortunately, as just like polio, there is no effective treatments to stop deterioration of post-polio syndrome either or to reverse the deficits. The only symptomatic management entities, they can be non-fatiguing exercises, endurance training, or assistive devices for mobility, encouragement, as well as counseling of families. Trials are underway in the United States and worldwide to learn more about this condition. So that brings us to polio vaccines. So as I mentioned, polio is devastating. Polio is debilitating with no treatment. Mostly the paralysis is permanent and there is absolutely no cure. So the only way to prevent polio is vaccination. And that's why we should be all stressing the importance of vaccination and keeping up the high rates of vaccination coverage across the country. As far as polio vaccines are concerned, there are 2 types of polio vaccines: the inactivated polio vaccine, commonly called IPV, and the oral polio vaccine, commonly called as OPV. So the inactivated polio vaccine contains types 1, 2, and 3 polioviruses that have been chemically killed with formalin. Viruses cannot replicate, infect, or cause disease. IPV induces effective humoral blood immunity, but limited intestinal mucosal immunity. As a result, it is very effective at preventing paralysis, but it has only limited effectiveness in decreasing transmission. It's the vaccine of choice for non-outbreak countries, such as the United States. And actually, it's the only vaccine currently used in the US since 2000. On the other hand, oral polio vaccine has been used globally for eradication efforts, and I'll go over that in more detail. It's the live attenuated vaccine. It contains live weakened polioviruses. They replicate in gut and the virus is shed in stool. It prevents paralysis as well as transmission of polio. It's given orally in form of 2 drops. The vaccine of choice for developing countries and countries experiencing polio outbreaks. If allowed to circulate in under-immunized or immunocompromised populations for long enough, it can revert to a form that causes paralysis. So vaccine-associated paralysis actually occurs as one case per 2 to 3 million doses administered. And it's a very rare side effect compared to the benefits highly outweigh the risks when we see that billions and billions of doses have been given across the world. So this figure shows us the history of polio and the dramatic decrease of cases in the United States since the introduction of the vaccine. So the immense success that we have seen since the introduction of vaccination. So in 1955, inactivated polio vaccine or SAP vaccine was introduced. And in 1961, oral polio vaccine developed by Sabin was introduced. In 1963, trivalent oral polio vaccine was introduced. And with widespread use of the vaccines, in 1979, we experienced the last indigenous wild-type poliomyelitis case in the United States. In 1994, Americas were certified polio-free. And since 2000, only inactivated polio vaccine has been used widely. Talking about the global polio eradication progress, the Global Polio Eradication Initiative, or GPEI, was established in 1988. And with the help of philanthropic organizations and with widespread use of pulse polio campaigns and targeted polio campaigns across the world, we did achieve eradication of polio from majority of the world already. So in 2014, polio was eradicated from India. And in 2015, wild poliovirus 2 was noted to be eradicated. So right after this, in 2016, Sabin type 2 virus was withdrawn from the OPV preparation. So as I was mentioning, trivalent OPV was used for global eradication efforts. But since 2016, type 2 has been withdrawn. So it's bivalent OPV, which is in use now across most of the world. And it uses strains 1 and 3. In 2019, wild poliovirus 3 was noted to be eradicated. And as of now, only 2 countries, Pakistan and Afghanistan, have endemic wild poliovirus 1 transmission. Although many countries and many across Africa and Israel, including Israel, have noted vaccine-derived poliovirus outbreaks. So what is vaccine-derived poliovirus? I'll explain that. So vaccine-derived poliovirus strain is a strain that is related to the weakened live poliovirus contained in the oral polio vaccine. If allowed to circulate in under-immunized populations for long enough, the weakened virus can revert to a form that causes illness and paralysis. And as I mentioned, outbreaks are most commonly caused by type 2. And because of this, type 2 was withdrawn from the oral polio vaccine preparation in 2016 once it was declared eradicated, the wild type. As the risk of importations of wild poliovirus and vaccine-derived poliovirus from other countries continues, it is highly critical to maintain high vaccination coverage worldwide, including in the United States. So when a community has high vaccination coverage rates, the weakened virus really, is not transmitted to that level and the spread is really controlled. However, if it is allowed to transmit in a community with low vaccination rates, then there is more risk of it being reverting back to the wild type and the neurotropic form that causes paralysis. And that's what exactly happened in the United States recently in New York when we saw that case from Rockland County, because the vaccination coverage rates there are as low as 60%. In most of the United States, it's fortunate for us that we have coverage rates, national coverage rates of more than 90%, which is very encouraging. So if the wild, if the vaccine-derived poliovirus does enter a highly, vaccinated community, there's a wall of immunity, and so it doesn't spread. But if it's allowed to spread in under-immunized communities, that's where it can strike and really produce a paralytic poliovirus cases. So all the more important to stress the importance of continuing the high vaccination coverage rates and keep up the good work. So to that end, the ASCP, CDC ASCP recommendations, they recommend every child to be receiving poliomyelitis vaccine, and routine childhood schedule is really, simplified. And if you look at it closely, the child already receives the 3 doses at 2, 4, 6 months, and the 4 dose at 4 to 6 years. This is the routine immunization recommendation. And most of the children in the United States already receive IPV as a part of their routine childhood immunization. So the important thing to see here is that 4 doses are recommended for all children 18 years and under. And the first 3 doses are separated by a regular interval of 2 months. That's the regular recommendation. But there are exceptions that I'll discuss. And the 4 doses given at 4 to 6 years of age. And these are the vaccine products that are available that contain IPV vaccine. IPOL is the only vaccine which is a standalone IPV containing vaccine. The rest are combination vaccines, which are commonly used in infants and in children. So according to the ASCP recommendations, at least 1 dose of polio vaccine is needed after age 4. Now, 4 doses is not necessary if the 3rd dose was administered at age 4 itself or older, and at least 6 months after the previous dose. That's the exception. And then children who have received 4 doses or more before 4 years, for instance, during infancy, for need of travel, etc., they do need an additional dose, which should be given at least 6 months after the next to last and the last dose, and should be given preferably at age 4 or older. So in case of accelerated protection need, for instance, for travel to polio endemic areas, for instance, we are, we can follow the minimum age and minimum intervals. So the minimum age for polio vaccine is 6 weeks or older, and minimum intervals between the first 3 doses can be as little as 4 weeks, with the 4th dose given at 6 months. If the accelerated schedule cannot be completed before leaving the country, then the remaining doses should be given in the visited country or upon returning home at the intervals recommended. In addition, children completing the accelerated schedule should still receive a dose of IPV at 4 years of age or older, as long as it has been 6 months since the last dose. So how effective are these vaccines? Polio vaccines are highly, highly effective. IPV in adults produces 90%. 90% of recipients are immune after 2 doses, and 99 to 100% of recipients are immune after 3 doses. In children, after 4 doses. The duration of immunity for IPV is not known with certainty. However, experts do say that the protection lasts for decades. For OPV, the protection lasts lifelong. So how do you interpret this in context of OPV that has been received overseas, or for international people who are coming, who have only received OPV? So in that case, a person is considered to be fully vaccinated according to the CDC if they have received 4 doses of any combination of IPV and trivalent OPV, or a series of at least 3 doses of IPV or trivalent OPV. And the last dose in either of the series should be given after 4 years of age and at least 6 months after the previous dose. So either you should have received 3 doses of IPV at the recommended intervals, or 3 doses of trivalent OPV, or else 4 doses of combination of these two in any combination, and the last dose should be given after 4 years of age. Now, if outside the United States, when you have received OPV, then how will we determine whether it was trivalent OPV? Because trivalent OPV is the only recognized, OPV vaccine according to the CDC recommendations. So to make that determination, we can probably use the date of administration to make a presumptive determination. So because trivalent OPV was used throughout the world prior to April 1, 2016, so if the date of administration was prior to that, then we can safely assume that the patient did receive trivalent OPV and could be considered valid. But if a patient, for instance, was born in 2017, then obviously the patient did not receive trivalent OPV, just received bivalent, which is not considered to be a valid choice for considering them to be fully vaccinated. And in that case, IPV should be administered according to CDC ASCP recommendations. So persons 18 years of age and younger with doses of OPV that do not count towards US vaccination requirements are required to receive IPV according to CDC ASCP recommendations. So for adults, what are the recommendations? So in general, the CDC states that most of the adults in the United States are considered to be protected if they have already received polio vaccination during childhood. Now, most of the adults in the United States have received vaccination during childhood, but there might be exceptions, as we saw in the New York County, like adults might not be immunized fully. So if they are not, then they need to be caught up on their IPV vaccination. The recommended number of doses is 3 doses for adults at recommended intervals. So 2 doses separated by 1 to 2 months, and a third dose 6 to 12 months after the second dose. And if accelerated protection is warranted, for instance, for travel to polio endemic areas, etc., then we might be able to use minimal intervals, which is 4 weeks between the 3 doses. So specifically for adults at increased risk of exposure, any unvaccinated adults should be vaccinated fully, okay? Because this list includes travelers who are going to countries where polio is endemic, or lab and healthcare professionals who will be handling specimens or who will be taking care of polio patients. Also caregivers who will be close contacts with the poliovirus infected patients. Unvaccinated or incompletely vaccinated adults whose children will be receiving oral poliovirus vaccine, for instance, international adoptees or international refugees in that setting. Unvaccinated or incompletely vaccinated adults living or working in a community where poliovirus is circulating. So all these adults are at increased risk of exposure and need to be caught up on their poliovirus vaccination. Is for adults who have previously completed series but are at increased risk for exposure, including international travelers, lab workers handling poliovirus specimens, and healthcare workers taking care of polio patients. They may receive a single lifetime booster of IPV according to the CDC. So these are the categories who may receive a single lifetime booster for IPV, and that's recommended. For any incomplete series, we need to administer remaining doses based on the immunization history, depending on, the catch-up schedule as CDC recommends. However, if there is a valid documented series, then there is no need to really restart a valid documented series where the minimum intervals were met. So what are the contraindications and precautions? So anaphylaxis after a previous dose or to a vaccine component are the only contraindications to receiving poliovirus vaccine. As I mentioned, polio vaccine is extremely safe, and the vaccine does contain minute amounts of streptomycin, polymyxin, or neomycin. So any anaphylactic reactions to these in the past are contraindications. The only precautions are pregnancy and moderate to severe acute illness with or without fever. And as I mentioned, the adverse reactions are very rare. Only local reactions, pain, redness, and swelling are the most commonly experienced. And otherwise, it's a very, very safe vaccine. It's a very, very effective vaccine. And we must encourage vaccination at all levels just to keep up the great vaccination coverage rates, which we have maintained historically, and we just don't want to be dealing with circulation of polioviruses in our highly developed economy in this day and age. So that's what I wanted to stress as one of the taking points from today's talk. So to summarize, poliovirus is highly contagious. Paralytic poliomyelitis is preventable. Unfortunately, there is no cure. There are 2 types of vaccines which are highly effective: oral polio vaccine used mostly around the world, and IPV, which is used exclusively in the United States. There is no treatment. Management is only supportive, and isolation of the hospitalized patient with contact and sometimes droplet precautions is recommended. Public health reporting is mandatory. And as I mentioned, it's highly urgent to report any case of poliomyelitis within 4 hours. The state health should be contacting CDC. And then in approximately 25 to 40% of adults who had paralytic polio during childhood may develop non-infectious post-polio syndrome. 15 to 40 years later, it's a devastating disease. It's a debilitating disease. And the only way to prevent it is by maintaining a high vaccination coverage rate in the country, and also very close, attention to hand hygiene is also warranted. So with that, I would like to thank you all for your kind attention, and will hand it back to Jill for the next section, and we'll be happy to take any questions at the end. Thank you so much.
Thank you so very much, Ashlesha. It's just such a lot of information packed into there. So thank you for that. And I have been working on some of the questions in the Q&A already, and I know that Ashlesha will turn her attention to a few of those, and then we'll save out some that require a little bit more explanation for the Q&A at the end. I would like to introduce next Jake Fray, and he will be discussing the laboratory testing and considerations for polio. Thanks, Jake.
Good morning, everybody. I'm going to be going over polio testing in the laboratory. So the first type of polio virus testing I want to discuss is antibody testing for types 1 and 3. I'm using the example performed by ARUP. This test is available Monday through Friday. It has a 6 to 12-day turnaround time and uses semi-quantitative serum neutralization. The specimen is going to be a red top with the serum separated from the cells within 2 hours of collection and transferred into the special serum transport tube. As far as your reference interval goes, less than a 1 to 10 ratio means no detectable poliovirus antibodies. 1 to 10 or greater indicates antibodies to poliovirus detected, which may represent prior immunization from a vaccine or current or past infection. CDC polio investigation for labs. So virus isolation culture is the most sensitive method to diagnose poliovirus infection. Your best sample is going to be stool collected 24 hours apart from patients with suspect poliomyelitis and collected within 14 days from the onset of the disease. Virus isolation is much more difficult and less likely from blood or CSF specimens. RT-PCR is used to differentiate wild strains from vaccine-like strains using the virus isolated from the culture, the stool culture, as the starting material. The CDC also can use partial genome sequencing to confirm poliovirus genotypes 1 or 3 and determine likely geographic origin. Serologic testing or antibody testing can also be done at the CDC using those red top serums and can help with diagnosis. And one sample should be obtained as early as possible from the onset of disease, and one more obtained during convalescence 3 weeks later. So this slide discusses specimen collection, storage, and shipping to the CDC. So for polio isolation and genotyping, the test codes listed: your specimen, stool, cell culture isolate, FTA cards, or wastewater. If you're transporting stool, do not add any transport media into that, and they will need 10 to 20 grams in a plain container. For wastewater, you want to refrigerate after collection and frozen prior to shipping, at least 500 mils. Tissue culture, at least 0.5 mils, and it's about a 3-week turnaround time. So this slide is referring to any labs that wish to keep polio virus. So any labs that want to keep wild poliovirus, vaccine-derived poliovirus, or oral polio vaccine-derived virus from blood, CSF, stool, or other infectious substances must apply with the CDC to become a poliovirus essential facility. To do this, they have to meet the requirements outlined in the GAP3 document, which includes increased biosafety measures over and above current laboratory standards. This is to prevent the poliovirus from being reintroduced back into the community. This designation is done by WHO, World Health Organization, and includes verification visits and annual inspections and audits. Labs would need to create additional policies and procedures defined specifically by that GAP3 document and follow all of those criteria. So this is really similar to our Joint Commission laboratory standards. They're very specific. And that's all I have today. Thank you.
All right. Well, thank you guys so much. Greatly appreciate all of this information. I feel like as someone who's been in healthcare for a very long time, polio is one of those terms everyone's familiar with. And yet I think how little most of us know about polio has been really humbling. And so it's great to have a lot of those gaps filled in. I want to start the question and answer session first by talking a little bit about hospital-based infection prevention and control and the implications for healthcare workers for polio, or the possibility of seeing a case of polio. So first, I just want to say quickly that I know that there is an EPA, of course, maintains their list of disinfectants. And for poliovirus, that is found on the EPA Q list for a tier 3 virus. Bleach and bleach wipes are the recommended disinfectant. Many of the other disinfectants that are commonly used in hospitals, 70% ethanol or isopropanol, or the quaternary ammonium compounds, are not reliably effective against polio. And there is, my understanding, and please, Ashlesha and Jake, my understanding is that environmental persistence is not only possible, but it can last quite a while. So we want to make sure that people are doing a great job of both cleaning and disinfecting in a hospital environment. And Jake, I wanted to ask you, are there special considerations for equipment that might be used in the laboratory, or things that you would want the laboratorians to be aware of from an IPC standpoint when it comes to like handling polio specimens?
Just to make sure that you always use those laboratory standard precautions. So gloves, lab coat, protective eyewear, not touching your face while working with specimens. It's the same precautions that we use for almost all infectious substances.
Excellent. And then Ashlesha, I think one of the questions that came through was about the idea of protecting healthcare workers. And is there a need or a thought that perhaps healthcare workers who might need a booster of some kind, or what is your thinking about healthcare worker protection and polio vaccination?
Yeah, so that's a great question, and great summary of so many questions here. Definitely, CDC ASCP does recommend that for healthcare providers who might be dealing with polio patients, who are taking care of polio patients, and also healthcare personnel, lab personnel in particular, who are dealing with polio specimens, they might be, they may get a lifetime booster. So just a single lifetime booster, IPV, is recommended in those populations. So that's where CDC has put out the recommendation. For general adults, just out of the healthcare workers, they have not been, they just say that most of them might be already vaccinated, but if not, then they should seek to complete their vaccination and being up to date on, any incomplete series. But for these two categories, they do say that, yes, they can receive a lifetime booster.
Thank you. That's great. And then there were a couple questions about immunity in the Q&A, and really about this, first of all, the discrepancy in the full immunity that's provided by the bivalent or trivalent vaccines. Can you speak to that for just a second?
Yeah, so the trivalent, the OPV initially introduced, for all the global efforts was the trivalent vaccine. And then because of the eradication of wild poliovirus 2 in 2015, in 2016, it was taken off, the type 2 was taken off. So only bivalent preparations containing 1 and 3 are available since 2016 for around the world. But they are being used in conjunction with IPV, which contains all 3 strains. So globally, in different countries, they are doing a combination of bivalent OPV with IPV together, so that if any any gaps in immunity might be addressed because of that. Because there is minimal heterotypic immunity, as I said, so all 3 viruses have to be given to in the form of vaccine, have to be given to an individual to produce immunity to all 3. So initially, trivalent OPV was doing the job all by itself, but in place of that, now we have bivalent OPV and IPV in combination to address those gaps.
Thank you. Jake, I don't know if this is going to be in your wheelhouse or not, but I'm not, you would probably be the one person that might have the answer here. And that's about rapid tests. Do you know if there's any work being done to be able to get more rapid testing out to facilities and communities that might experience outbreaks?
I don't. I should have looked into that, but I didn't. I've never heard of any point of care testing for polio, but it's something I definitely like to find out.
Yeah, I think we all discovered how quickly with COVID that a new pathogen could get testing out pretty quickly when we put a lot of attention to it. And of course, polio is one of those things that we hope to never have the size of an outbreak that we have seen with other things. But I think certainly the desire in communities to be able to respond quickly is perfectly reasonable. All right, a couple more questions here that I would like to get through. Many of them having to do still with vaccines and the new polio vaccine. And Ashlesha, I wonder if you know anything more about the timeline for that or the duration of the immunity.
Yeah, so the booster that they are recommending is the IPV, single dose IPV booster. So for IPV, most of the people, including the experts at CDC, they kind of, agree to the fact that the immunity might be long lasting, at least for decades. And that's why they are saying that adults in the United States are mostly protected because they did receive IPV as children. So the duration of immunity is prolonged and usually lasting for decades. For OPV, they usually, agree that the protection is lifelong. So lifelong immunity with oral. So if anybody has received OPV, then they are protected lifelong. So it's usually long lasting. They're very, very efficient. And the protection offered, I think one of the questions asked about the protection offered, it's more than 99 to 100% with 3 doses in adults. And with, if they have already received it and now they are boosting on top of that, it's like, yeah, you're fully protected with that.
Excellent. And I know, Ashlesha, earlier in your presentation, you mentioned a few things about symptoms. And I think there's a good question in the Q&A about, for instance, school nurses, people who might be on the front line seeing things. Are there things that, especially in high-risk communities, in communities where people know that their vaccination rates may lag, or where they may have larger populations of those either unable or unimmunized, that they should be watching for? What are the sort of things that you want to put in somebody's mind? Gosh, if I see this, I want to be thinking that this could be a potential case of polio.
Yeah, so specifically in those settings, as you mentioned, probable case is defined as sudden onset of weakness, areflexic and atonic paralysis in one of the limbs. Like that's the classic presentation. And certainly in an unimmunized child or who has traveled from abroad or who has not really received any vaccines, like that kind of a setting would be, the right setting for the diagnosis. The paralysis, as I said, is sudden and it's floppy with no reflexes, and it leads to permanent disability. So the patient is unable to walk and, they're just disabled for life. And the other thing to watch for, because why do we want to recognize it? Not just to, mention and, diagnose it as polio, but also to monitor the child, because in some of these instances, it might progress to respiratory failure, as I was mentioning. So it can lead to cranial nerve paralysis as well, and, higher system involvement as well, and leading to respiratory failure. So that's the main reason why we want to diagnose. And plus, you want to prevent transmission in the community. So just noting these signs of paralysis suddenly, acute flaccid paralysis in anybody is reportable, is notifiable. So as soon as you detect it at the school nursing level also, you must notify your local health department, get the child to be admitted immediately in an isolated environment, in a separate room, etc., with strict monitoring of the status as well as of the stools, excretion, etc., and also close household contact tracing, because, if people around him might be already carrying and transmitting the virus, and we don't want it to the virus to keep transmitting and set him also low vaccinated status in communities, because that's what leads to more paralytic cases.
Right. And then is there, for those folks who may not necessarily have their immunization records or may have traveled from outside the country or don't know their immunization status, is there a way to test for immunity to polio? I know you get these great, very, very high rates of take, but for instance, if someone is not sure, is there a way to test like we do for some other things?
According to the CDC, no. You just rely on records, and you see if like somebody has, if records are missing, you're not really sure. They certainly remember in their memory that, okay, I did not receive this vaccine for some reason, then those are the people that you need to catch up on vaccination. So, and especially if they are living in communities with low levels of vaccination or with known community transmission. For instance, the counties in New York, for instance, who have, which have been shown to have low vaccination coverage rates. And we know from wastewater sampling that the virus is circulating in those communities. Please bring them up to speed with the vaccination. So, just are on the side of vaccination in that setting.
Yeah, I think for a lot of us, we didn't think about being able to find our vaccination records, and we just either assumed or thought that we must be covered. And if we are in a community where we might have a higher risk, then I think pursuing that is certainly reasonable. There were a couple more questions I wanted to see if we could get to. I know we're getting sort of close to the end of time here. For most of us, or for most of us of a certain age, I guess, if we're not sure about vaccination, the current advice would be, if you're at risk or if you're a healthcare worker at risk, then would be to get a dose of the oral polio virus. No.
The injectable, the IPV.
Injectable
that's
IPV.
That's the only vaccine which is available in the United States.
Right.
Oral polio is only, so let me clarify. Oral polio is only used globally outside of the United States. The only condition in which you would use a monovalent preparation of the type 2 or a bivalent preparation or any other oral polio would be to contain pandemic level or epidemic level situations. So God forbid, if there were an outbreak or something, then we need to control it immediately. Then we would be using, live oral polio vaccine in that setting. Okay. CDC has not issued any advisory as of now. Its only recommendation is to give only IPV to catch people up with the IPV vaccine, which is the inactivated injectable vaccine given by subcutaneous or intramuscular injection. That's what is given for routine childhood immunization. That's what is being recommended as the booster for adults who are at risk, or even for catch-up immunization of adults who are incompletely immunized or are at risk. So only recommendations are pertaining to IPV, not really to OPV at this point. OPV is only used in outbreak situations and like bad situations where, fortunately, we are not yet, and we don't hope to be there. So please maintain your high rates of vaccination so that we don't come to that at all.
That's right. And so if we were, for instance, we're dealing with in a refugee or immigrant community and we're not sure about the status, then we would be giving the immunization, the injectable immunization, to catch people up if we were not clear, or if they might have only had perhaps underdosed in the past, or incomplete series.
Right. And also if they had just bivalent, for instance, after 2016, if they received any OPV, then that doesn't count either, because the only thing that counts is trivalent OPV given before 2016. And, also like 3 full doses of that. So if anybody has less than that, then it's not counted and we have to give them IPV anyways.
Yes, I think that's really, I think, a great takeaway. I know we're coming up on the last few minutes of this. Let me tell you all, I just want to thank you so much for this. We will be putting together a blog post on netec.org that will contain some of the pearls from today's session. I want to thank Dr. Ashlesha Kaushik and Jake Fray for their just amazing amount of information that we've been able to get through today. If you still have questions, please Feel free to continue to send them in. We will try to capture those and answer as many as we can in the blog post. I'm going to go through just a few finishing touches here. We have some of the references that are here listed that have been used today and that you can use as outside references for more information about polio. NETEC, again, is here to help. We are continually looking for new topics to cover and to answer any questions you might have that will increase your preparedness or the preparedness of your healthcare system for special pathogens of any kind. You can send them to info@netec.org. Those get triaged to appropriate subject matter experts. You can also send a request for technical assistance to netec.org. And we try to give you in place or via things like Zoom, technical assistance about all sorts of questions, whether it's reviewing protocols and policies, PPE ensembles, lab processes, and we have great experts in many, many different areas of both from EMS to laboratory to pediatrics to all sorts of special populations. So please feel free to reach out to us. Please join us on any of our social media events. We also have the e-learning center where we have courses. We have a podcast called Transmission Interrupted. And again, if you have questions, please submit them. Thank you so much for your attention today. We really appreciate everything. Is there any last few moments you want to get in? Anything else, Ashlesha or Jake, that you would like to get off of your minds and into people's brains today?
Yeah, so I would just like to end with saying that, please maintain high vaccination rates in your communities. Please be the pro-vaccination voices in your communities, because we just don't want to, be misled by any misinformation and really fall prey to resurgence of such diseases, which could have been, a thing of the past. And it's really sad that we are still, in New York, we saw a case. So just don't let the vaccination rates dip, and don't let the anti-vax, just convince people with misinformation. So just get your word out there that, hey, polio is bad. We need to protect, we need to keep up the childhood vaccination rates high. We need to keep up the good work. Thank you.
All right. Well, thank you guys so much. I want to thank our speakers today, Ashlesha and Jake, for all the information they've been able to convey. And we will do our best to answer any of the remaining questions. Thank you all for your attendance, and we look forward to seeing you again. Bye-bye.